how and why does the labia change? Because it does, right? Is it just childbirth? Is it age? Is it menopause? Why is that labia?
It's a combination of all of those things that you described.
Okay. Welcome to MENO with Jacqueline Buckingham, the authority on menopause, perimenopause, and wherever you are on the pause spectrum. I'm Jacqueline Buckingham, founder of MENO, and firm believer that menopause is status, not a sentence. If you're here, something in your body or your life is asking for your attention, and you're not meant to navigate that alone. In our first 2 seasons, we started this conversation, won an Anthem Award, and brought you the leading experts before they were on Oprah. Now we're raising the standard. Each week, I bring you the verified providers, menopause specialists, and authorities you need to understand what's happening in your body and what to do next. From the gold standard in HRT and the little pink pill for sexual desire, to the conversations no one else is having about relationships, identity, and mental health. This is the full picture of your health, because this stage of your life is not just about symptoms. This is about how you live, how you feel, and how to embrace it all, because you have arrived. Pausing or not, start here. This is MENO with Jacqueline Buckingham. My next guest is Dr. Michael Reed. Dr. Reed is a board-certified OBGYN and skilled cosmetic gynecologist. With over 22 years of experience, Dr. Reed prides himself on his compassionate manner and staying current on the latest advancements in cosmetic gynecology. He completed an 18-month fellowship with Dr. Michael Goodman, a leader in the field of women's sexual health and cosmetic gynecology. In this conversation, we talk about vaginoplasties and labiaplasties. Here is my conversation with Dr. Michael Reed. Let me just start with, I love your pin.
Oh, yes, my little vulva here.
Where did you get it?
A good friend of mine, she is in Arizona.
Okay.
And we have always stayed in connection. She's a physician as well.
Yeah.
And she knows my passion about caring for women. And she thought, next time you go out and do some speaking, whether that's in Dubai or India, wear that pin for me.
It looks so good. And you don't notice really what it is. It looks very modern art.
I love it.
So when I met you just a couple weeks ago, which was so much fun, I loved that conference. I learned so much.
I agree.
And it was really wonderful to meet your wife, Abby, too.
She's been a pleasure.
Oh, she's amazing. Yeah. And what I think is so unique, too, is that you run the practice together. Yeah.
It was something that we did jointly.
Yeah.
It was a decision that we made together. I mean, because we were in Omaha, Nebraska, Midwest, the heartland.
Okay.
Right? And I had been practicing there probably 18 years. I had a large following.
Oh, a long time.
10,000 plus patient panel, 5,000 deliveries. I was chairman of the department for about a decade.
Wow.
And I had some personal changes and talked to my wife. And she said, well, I think you can. You're saying California, right? Because of all the places that she would want to live would be California or Nebraska.
All right. Now, what was the impetus of this even conversation about moving? What was it?
So if we rewound a little bit.
Yeah.
I sit in this chair very comfortably.
Yes.
At one point, I was 340 plus pounds.
Okay.
And lost some weight, did some surgery to lose weight.
Yeah.
No problem. Not ashamed to say it because I feel better, feel good.
Okay. Right? What'd you do? Can you tell us?
I did a gastric sleeve.
Okay.
I call it the fat man. That's what I call it because I was fat. But now I think I'm doing pretty good.
And how was it? How was that experience?
It was great. It was laparoscopic.
Wow.
I did a lot of work and exercise and lifting weights. And then it turned out I had all the skin everywhere.
Yeah.
Right? And it's just kind of like this reminder of where you were and what you used to do, right? Being big and in the past.
I see. Right.
So I went to Beverly Hills.
Yeah.
And I got an abdominoplasty.
Okay.
Flattened me out.
Yeah.
And I just felt so good. I felt so empowered. I was like, I'm ready to take on the world. And I talked to Dr. Katzen and I said, man, you got to feel good to do this for other people, don't you?
Yeah.
He said, well, you're a doctor. I said, yeah, I'm OBGYN. We deliver babies and care for women. He said, go check out David Matlock because there's a lot you can do.
This is how it began. Yes. I didn't know this. I love this story.
Yeah. I found Michael Goodman, who was in Davis. Right.
And Michael Goodman is like the pioneer.
He is really
one
of the pioneers.
The grandfather.
Yes, he is.
Right?
Yeah, he is one of the pioneers.
Yeah.
For sure. He, just to give you a little background, he's been around for a long time.
Right.
He has really, as far as cosmetic gynecology,
Yeah.
right? He has really created a lot of validity for the fraction of medicine called cosmetic gynecology.
Yeah.
I mean, he wrote the first textbook in female cosmetic gynecology. He's got at least 10 scientific papers out there.
Yeah, I mean, he's the guy.
Yeah, he's
Dr. Goodman is the guy.
Yeah, he's a great teacher. So I did training with him. He called me on my birthday and he said, hey, I've never done this. I'm going to be retiring soon.
Yeah.
And, if you want to come out, watch me and I'll proctor you. And, I think when we get done and retire, I think you'll kind of be positioned to be the next generation to kind of carry on cosmetic gynecology. I mean, I couldn't pass it up, right?
That's being like verified.
Yes.
Absolutely.
How am I going to pass that up?
I don't think you can pass that up.
Right. So I brought that to my wife.
All right.
She listened. And then, I don't know if you know this, but I have 6 children. My oldest one is 25.
Okay.
And my youngest one is 4.
Oh my God. You beat me on that. I've got the 10-year span of 27 and 17, but 25 and 4?
Yes. It's fun, though.
Yeah, it is so fun. It's amazing. 6 kids.
Yeah. And I brought that up because I had to get permission from my middle daughter because she was a senior that year.
Oh, senior in high school?
Yeah.
I've got one of those right now.
Yeah, you know what it's like.
I
You get
do.
kind of scared.
It's a big deal.
They're leaving a little bit, but then they're coming back. They're going off to college, the empty nest. And it was just the opposite. In this case, I'm leaving her.
Right.
So I had to get permission from her.
Sure. What'd she say?
She said, sure, Dad. She said, sure.
Well, did she stay in Nebraska and finish it out?
She stayed in Nebraska. And then I came back to Nebraska, of course, for her graduation and to support her and lift her up. And it was a great experience. But got a permission from them. But I gained the education, developed the roots to grow and just really contribute to cosmetic gynecology. I just have just this unwavering commitment to this stuff,
So that was really what took you from being a regular OBGYN,
Yes.
delivering babies and doing pap smears and all of that kind of a thing,
Absolutely.
to the cosmetic gynecology that you do now, which is labiaplasties, vaginoplasties. You do non-invasive procedures as well.
Yes.
But that was really the thing, is you felt different. You were like, I want to give this to other people. I mean, you don't have a vagina, obviously, and you mentioned that in one of your YouTube videos, which I really appreciated. And I just think it's amazing, too, that you can actually show a for real labiaplasty on YouTube.
Yeah.
I told you I was watching one of your videos, and it was all draped, so all you saw, was the anatomy right there.
Right. We got to respect the patient.
And so I thought it wasn't real. I thought it was like not real person. And then you're like, Sarah, are you okay? And I was like, what? Oh my God. How do you talk Sarah into doing that?
Patients that seek this procedure or these procedures and treatments understand that their comfort, their happiness, and their ability to thrive is not dependent on others. It's dependent on what they would want and how they want to be.
Okay.
And so oftentimes they're okay with it. And then I also say, well, when you came to see me, you looked at pictures that look kind of like you.
Okay.
You looked at outcomes and said, I think I'll go see Dr.
Right.
So you want to be able to empower women the same way by allowing them to see you.
And
because you may have similar anatomy to someone else.
That's right. And they're not showing their face.
They're not showing their face. Sarah's not a real name either, by the way.
I figured.
Okay.
I figured. If you're going to go and get a nose job, you can easily go on the internet and see before and after nose jobs all over the place and pick your doctor accordingly. But if you're thinking about something like a labiaplasty or a vaginoplasty, I'm going to guess that it would be a little bit more difficult to find those before and afters. Is it?
If you can find the before and afters, if you find the right physician.
Okay.
In fact, I have this kind of I've developed a form that helps you choose a surgeon. But in general, when you're trying to pick this type of surgeon, you do want to look before and afters on their website.
Sure.
You'd like to see if they have some information dedicated to the procedure that you're interested in.
Right. And so could the pitfall be that someone goes in to a surgeon, or maybe they go to an OBGYN, and the surgeon or the OBGYN says, yeah, sure, I can do a labiaplasty, but they might not have done a lot of them, and therefore the person could get kind of botched? Is that what happens?
That's exactly. I mean, most of the botched surgeries that often occur with the board-certified OBGYN.
Really?
Yeah. So we're wonderful people, right?
Yeah, I would think so.
OBGYNs, you know, we bring life. We're part of delivery, and
Totally.
we develop trust, and you
Yes.
trust us. We want to help you. We're good people. And you say, you know, I have a little bit of labia here, and it's kind of bugging me. Do you think you can get it out of the way? And the doctor says, well, you know, I operate in the vulva all the time.
Oh.
It can't be that hard. I mean, it's just labia. Couldn't you just kind of pull and cut? That's totally not true.
Okay.
But the physician doesn't know that, and the patient doesn't really know that.
Got it.
They think, well, that's the OBGYN, delivered my baby, I trust it. Perfect fit. Why not?
Well, isn't
right?
this absolutely?
Yeah.
I mean, I can see how someone would just translate that trust of you delivered my baby,
Yep.
or you've taken care of me for years and years and done my pap smear and everything else.
Mm-hmm.
So why not? It would actually, I totally get how somebody could get there.
Yep.
There's ACOG for obstetrics and gynecology.
Yes.
Am I right?
Yeah.
And there are the different, plastic surgery associations.
Absolutely.
But right now, there's not any association around basically female sexual health surgeries.
I would agree. I mean, the closest thing that we have is ISCG, International Society of Cosmeto-Gynecologists, where we do meet once a year. We share little tips and tricks, educate newcomers into the field.
Okay.
But they have no power as far as creating a curriculum for physicians to go through.
Oh.
They don't have.
Why not?
Well, they have a little bit longer course, but the main reason is we need American College of Obstetrics and Gynecology to say this is important, and women are important.
Okay.
And so we need to change the way that we think.
Right.
And eventually, over time, ACOG is beginning to understand that these aren't made up procedures or procedures where we're just kind of marketing them.
Right.
They're different. They're inherently different.
Yeah, because right now, if I'm going to go be, let's say, an orthopedic surgeon or a microsurgeon, right? I mean, those are different. Those are different residencies.
Yeah, yep.
That's a different direction. Right now, there's no specific residency for these kinds of surgeries.
That's right.
If they're going to look for somebody, they're going to, one, they could use that form that's on your website and your Instagram.
Yeah, and I can send it over to you.
Well, perfect. Then we'll put it on ours too. And so they can use that. And then will they also want to know and also want to ask, okay, how many of these surgeries have you done? Where did you train? Who was your mentor? Are those fair questions?
Those are absolutely fair questions.
Okay.
Absolutely.
Okay.
And the reason why, and in my opinion, that botch is still happening and why these outcomes are still happening, I can only speak so much. I need some women, some huge pussy energy like yourself to get it out there and let people know that these things happen and there's safe ways to do it.
Yeah.
Because what happens is a woman may find somebody or trust that OBGYN.
Right.
And she didn't absolutely know how to do it, but she did it, and now it's not very good. So where does she turn? Who does she go to?
Well, evidently they go to you.
Well, they can. But, I mean, where does she go? There's women would say to another one, well, why would you even touch your genitalia? Why did you even do that to begin with?
Sure.
So she's like, well, where do I go then? Who can I confide in?
Yeah, I mean, let's actually talk about kind of the emotional and the stigma piece around it to begin with. Because this isn't something where most women that I know of, at least, are like, hey, I'm considering a labiaplasty, and the other woman's like, let me show you mine. Right? That's not a conversation I know about. But wouldn't it be good if we could get closer to that? Because then that way we wouldn't have as many botched procedures.
Right. Because then people would be sharing. People would be seeing. They said, no, that shouldn't look like that.
Right.
It should look more like this.
Yeah,
and then now she knows that that's not right because she didn't know before because she feels like she's the only one doing it.
Yes. Okay.
Right.
So how can we get closer to that? You're saying we could get closer by women just talking about it.
Yes.
when women come to see you, what are they generally coming in and saying? What's their concern? Why are they coming to see you? Because they're not coming to see you anymore for having babies, right?
No, they're not coming to see me. They're usually coming to see me because of, just to kind of, I do female cosmetic surgery.
Yeah.
I also do menopausal health.
Okay.
I'm a NAMS certified menopausal practitioner.
Tell us what NAMS is.
North American Menopausal Society.
Love it.
ISWISH member, International Society of the Study of Women's Sexual Health.
Yes.
Member of that and love that organization.
Great.
Yeah. So if they're coming in for labiaplasty, they're coming in with a functional and a cosmetic component. There's always a cosmetic component, but there oftentimes is a functional component.
Tell me about that.
Yeah, the functional component could be, I get in a bathing suit and things kind of fall out and I don't like to wear that type of bathing suit, or I can't. Good. Or before we have intercourse, I have to pull things apart. Or if I don't, I'm getting pinched and pulled in, and every time I have to kind of, hey, give me a second.
Why does a labia stretch out anyway?
Most of the time, they're not stretched out. It isn't like someone stretching. These women are born different.
Sure.
They're like snowflakes, right?
Okay, yes. Let's say someone is 50 years old and their labia looks different from when they were 20 years old. How and why does the labia change? Because it does, right? Is it just childbirth? Is it age? Is it menopause? Why is that labia?
It's a combination of all of those things that you described.
Okay.
So if you're having children, you're birthing, the vulva swells.
Yeah.
Anything that's stretched isn't going to always snap back. So you get a little bit of change.
But then why does that also affect the labia?
Because that gets really engorged too and swollen too.
Okay.
The labia majora get huge, the labia minora get huge.
So it just might not snap back all the way.
Yeah.
But it's not just childbirth, right?
Not just childbirth. Some of it is just their normal anatomy. That's how they were born.
Okay. All right.
A lot of times it is not due to childbirth because a lot of the women that are getting labiaplasty don't have children yet a lot of times.
We're talking about doing plasties to labia. Are we talking about minora or majora?
Sometimes in my practice, I'm doing just as many labia minora as I'm doing labia majora.
Okay, what are we doing to the labia majora? How are we, what are we plastying?
You're doing basically a facelift to the vulva.
Okay.
So we're removing skin, just like you do a facelift. You remove skin, and then you sew it over, right?
Sure.
Well, we remove skin from the vulva, and then sew it back so that the skin is tighter. And more youthful and more consistent with the patient's viewpoint of herself, the patient's feeling about herself. And to be able to see from top to bottom the work that they've been doing and see it all the way through. It's kind of like I did, right?
Okay, yeah.
Lost a whole bunch of weight. It was a constant reminder, right?
Right.
Same thing.
Okay, so it feels like it's for one of two reasons, or it could be for both, where it's functional and it's like, this is painful, this is uncomfortable, this is bothering me, or it's just, I don't like the way this looks.
Yeah, I have an ideal look of how I would like it to look.
Okay. All right. Yep. So what's the recovery like with a labiaplasty? Let's go minora first. Yeah.
So the standard is, so the first 3 days, you're taking it easy. You're icing it every 20 minutes while you're awake. You're taking it easy. You're not walking. You're basically Netflix and chilling.
Okay.
Literally or figuratively, however you want to take that.
Okay.
But you're just chilling, catching up.
So is it painful? Is it painful?
No.
Really?
I would say that most patients tell me on a scale of 1 to 10, it's a 2.
Really?
And it's usually only the first 3 days or so that might be a little problem.
Oh my God!
Like no driving for 5 days.
Okay, I wouldn't think so.
Yeah.
How about any intercourse? I would not think for a very long time.
I have a standard talk for sex. This is what I tell them.
Yeah.
I say for the first week, you and your husband act like you don't know each other.
Exactly.
Right?
Yes.
Second week, anything above the waist is fair game, so be creative.
Okay.
And at 3.5, if 4 weeks, self-pleasuring is fine.
All right.
You're okay if a partner goes down on you, but you need to keep a penis, finger, or toy from the inside of your vagina.
Sure. Everything out. Everything outside.
Everything outside.
Okay, got it.
Yep.
Same for the labia majora?
Yes. Labia majora, yes. Same thing.
Same thing.
Yeah, exact same thing.
All right,
same resting, same icing, same everything.
Okay, so we talked about labiaplasty.
Mm-hmm.
How about vaginoplasty? How is that different? What are we talking about? What are we doing in a vaginoplasty?
So in a vaginoplasty, this patient almost always comes to me and says, Doc, sex just doesn't feel like it used to. I said, what do you mean? She says, well, I don't feel that friction, or as I get more aroused and I get a little bit more lubricated, there's loss of friction, or he's falling out all the time.
Okay.
Or there's these audible sounds, queefing or vaginal flatus that occurs.
Okay.
Or I look down here and all I see is all this pink. What does all this pink and bulging come from? I don't want to look like that.
Okay.
Another thing that they will also complain was tampons. Tampons aren't staying in anymore. What the heck? What's going on? So these are all different changes of laxity that occurs.
Got it.
Now, laxity is basically looseness of skin with loss of structural tone with it.
Got it. Okay.
So you got to have some kind of muscular or ligamentous insertion to hold things, and then the skin loosens, and then what was holding it, like ligaments and those things, loosen, and now you have laxity.
Okay, got it.
Yeah.
All right. So how can you tell then if someone needs actually a vaginoplasty, so a surgical procedure, versus a non-invasive option like we talked about with
FemiLift.
Yes, exactly, with Dr. DeLucia. Okay, so that would be non-invasive because there's no cutting involved.
Right.
Vaginoplasty, there's cutting involved. Yes. What are you cutting? How do you know if you need to cut?
With energy-based devices, you get very modest amount of tightening.
Okay.
I usually quote 10% improvement in tightening.
All right.
So this is my rule. You're not going to find anywhere. But if I can fit 2 fingers and no more, and it's still snug around my 2 fingers, then you might find some improvement with the energy-based device.
I see.
If it's much more than that, you're not going to get the improvement that you would like as far as tightness. Vaginoplasty is designed to tighten the vagina and get full-length tightening of the vagina, get rid of scar tissue.
Okay.
It's the patient coming to me and saying they want these things are interfering with their ability to thrive. So with Western medicine, when you talk about traditional Western medicine, there has to be a dysfunction or something has to be broken. And then they'll go in and fix it.
Oh, okay.
So if you are having problems with chronic constipation, or you're having to splint, meaning putting your thumb in the vagina, pushing down so that you can pass stool, then you can get an anterior-posterior repair covered by insurance that will fix your difficulty with having bowel movements, but it's not going to change your improvement in sexual gratification.
Okay, but what was that thing you said about the finger and the what?
Oh, yeah.
Because I'm like, could you rewind a second? Because when you described that, I was trying to see it in my head, and I was like, nope, I can't see it.
Splinting. So like I told you, we talked about that women will sometimes complain about bulging that they see.
Yeah.
So if we look and we say this is the pelvic floor.
Yeah.
Or the cradle of civilization, as Carolyn DeLucia would say.
Yes, she would. The cradle of civilization.
That's right.
It's a good name.
Yeah. So when the pelvic floor is together, the rectum is right underneath.
Okay.
So bowel movements come out like torpedoes, right?
Okay.
All right.
Yeah.
So now the pelvic floor is separated.
Yeah.
So now there's bulging because the rectum now has a place to come in too.
Oh.
Right? So now the only way, to have a bowel movement, you got to fill up the pouch up here first. Then there's got to be enough behind it so that can come out. But then what was behind it now is filling up the pouch.
So this can affect like your whole gastrointestinal system?
Yeah.
Okay, that's pretty crazy. Okay.
And so most people are coming in for the reasons I just described. And we're not waiting for it to be broken to be fixed. We're fixing it to improve her ability to thrive. There is a in-site repair where we get rid of the hernia or rectocele. That's that pouch.
Get rid of the pouch.
Get rid of the pouch.
All right.
Then the next thing we want to do is bring the pelvic floor together so that you don't have the pouch anymore. And when you bring the pelvic floor together, you're going to decrease the internal diameter of the vagina.
Oh, so right there, that's going to help.
Yes.
Okay.
And then as we come out, we get rid of any scar tissue.
Okay. Scrape.
Oh, we actually cut it out and get rid of it. We don't want that anymore. Yeah, just like that.
You don't keep it.
No. And then we build up the muscles of the perineum surgically. So we make a pyramidal shaped incision at the perineum.
All right.
Take that out. And then we are looking at 3 different muscles. You have the bulbal spongiosus muscle, which runs right behind the labia majora.
Okay.
Then you have the transverse perineal muscles.
Yeah.
And then you have the pupil rectalis muscle. So it's the confluence of all of these muscles that develop the perineum.
Got it.
So when we take that pyramidal shaped incision and I have access to those muscles now, and I use suture and grab suture and bring those muscles together.
Wow. Yeah. That's pretty amazing.
Thank you.
That is really pretty amazing.
Thank you. But here's the killer. I don't even have to put you to sleep.
What?
I can do all of this.
I think I'd want to be asleep.
No, you don't. I can do all of this awake.
Awake?
We can talk. We can watch a movie.
Not even like Twilight?
No, you don't need to.
Oh my God.
You don't need to. I can also interact with you. So if I'm having a difficult time identifying the muscles for whatever reason, I can say, Jack, could you do a Kegel for me? And
got it.
I got it. Thank you.
There it is.
There it is. So those are one of the advantages of doing it under local. Not everyone does that, but it's great for the patient. They get to leave right away. They're talking to me. We laugh, we joke. But
they're all numbed. So you're not feeling anything.
Completely numb. Yeah.
Okay, and same with labiaplasty?
Absolutely.
Under local?
Yes. If a doctor is telling you got to go to sleep to do it, you might want to think about it. There's no reason to go to sleep to do a labiaplasty.
All right, let's go with your typical labiaplasty. Typical. Menorah.
Yes.
How long does that take?
With me, about an hour and a half to an hour and 45 minutes.
Got it. Vaginoplasty, how long?
Oh, that's going to be 2 hours.
Okay, majora.
About 90 minutes to an hour and 45.
Okay, so we're around 2 hours, in the hour and a half to 2 hour range.
Unless you start combining them.
Then we're longer.
Yeah. So if a lot of times there is combination. So a lot of times they end up operating for 3.5, 4 hours.
Yeah.
That's a recovery is a little bit arduous, I tell patients. It's difficult.
2 weeks?
The first 3 days are difficult.
Okay.
You're just going to be laying, sleeping.
Yeah.
Using the restroom, icing, and sleeping. That's what you're going to do for the first 3 days.
Okay.
After the first 3 days, you're beginning to move around a little bit.
All right.
You're still not driving.
Yeah.
At about 5 to 7 days, when you come see me again, you're driving.
Yeah.
And you're close to starting to look and feel a little humanoid, but you're not yet.
Yeah.
But you have that point, and then usually by about after that first week and ending the second week, you could walk around and nobody would really know that anything has been done.
Yeah.
You might be a little sore, but you wouldn't stand out. You wouldn't stand out.
Got it. Okay. All right. So how about like the misogynistic angle that sometimes these kind of plasties, the vaginoplasty, the labiaplasty, get, right? Like some people think, oh, does somebody else want you to look like that? Is that usually the case? Is somebody's partner going like, could you fix that, please?
Most of the time, the husband is going, why are you doing this? I love just the way you are. What's going on?
Oh.
Or there's nothing wrong. What do you mean? Why? I mean, it looks fine.
Sure.
They're just happy to be there.
They're happy to be there.
They're not thinking about how it looks. They're okay.
I wouldn't think so.
No. There was also a recent study where they actually looked at responses of women and men to the before labiaplasty look and one that has the ideal labiaplasty look, whatever that may be.
Yeah.
And what they found, there wasn't any statistical difference between the two groups. Women often liked the ideal look more than men, but when it came to the men, they didn't care.
They didn't care.
Like
you said, they're just happy to be there.
They're just happy to be there. But this is empowering, and I don't know, this is for you, right?
Yeah.
Just like the abdominoplasty was for me.
For you.
There's other people out there that have lost a whole bunch of weight, have a lot of flab, and they feel good. Yeah. They love themselves, and they're thriving. But in order for me to thrive, I wanted this off.
Yeah, got it.
So it's the same. It's the same.
It's the same.
It's the same. So I have to always, make sure that the husband understands that this has nothing to do with you.
Okay.
Right? It has nothing to do with it.
Yeah.
Your penis size is fine. No worries, because that's the first thing the guy thinks. Something wrong with, what am I not? Why is she want to get it smaller?
See, we always feel like, everybody feels like it's always their fault, right?
Yeah, right.
Like it's me.
Yeah,
like it's me. No, it's you.
Right.
It's really you. Here's what I'm, hearing a lot about, reading a lot about, and really want to have people prepare for so we're not fearing it all the time is menopause, right? I feel like menopause is something that's like the boogeyman times a million.
I think
I want to be excited about menopause.
You want to be excited?
I do. And I feel like you're the guy to get people excited about menopause. That's really why you're here.
Everything is mindset, right?
It's mindset.
It's how you feel about things.
Right.
So if menopause, andropause, men get andropause, low androgens, and they have
never
problems.
Hear about that. We never hear about andropause.
It's there. It's a real thing, and that's one of the other things. There's testosterone clinics anywhere. You can go to your family doctor and get testosterone, and you can get a little Viagra. You get a little Cialis, taking care of the fellas.
Okay.
Right.
So let's
because
take care of ladies.
Because it's real. Same thing for women. It's real.
It's real.
And you can really get better and feel better. It's not the panacea that's going to change the world, but it can make a significant difference in your life. So the only way you're going to know is to try it.
Yeah,
and if you can get rid of hot flashes, you can get rid of vaginal dryness, you can get rid of painful intercourse.
Okay.
You remove those things.
Yeah.
Right? Now your mind has more room to enjoy things that help you to thrive.
Exactly.
Right.
How about the perimenopausal symptoms? Somebody comes in and they're like, I don't know what's wrong with me, but I'm tired. I feel a little depressed. I'm not motivated to do anything out of my bathrobe ever. And I don't know what's wrong.
I got to get a history from you. What's going on?
Got it.
There's a biopsychosocial issue with everything in medicine.
Okay.
So I want to know, what's the history? What comorbidities do you have or not have? What medications are you on that you don't have?
Sure, because it could be your thyroid.
It could be. So then we got to check labs.
All right.
When was the last time you had this done?
Okay.
Have you had your testosterone level checked? That's something that usually dissipates and begins to get a little bit lower around your 30s.
In your 30s?
Yes.
Oh, wow.
So then you see that there's a change in confidence. There could be sometimes a change in your desire.
Yeah.
All these things.
If I go into my regular doctor and I go in for an annual physical, it is not standard procedure to check your hormones.
Okay. The reason is that we're not trained a whole lot to manage, believe it or not, trained a whole lot to manage menopausal health.
Oh, I believe it.
100%. So a lot of physicians are still living back in the ages of the WHI trial. The doctors are scared.
Okay.
They don't want to be sued.
Say a little bit about the WHI trial.
Women's Health Initiative was a study that was done. They looked at Prempro, basically, estradiol and bajoxyprogesterone.
Yeah.
This big thing came out and they said, oh my God, estrogen causes cancer. Stop HRT, get everybody off. You're going to have a heart attack. You're going to have a stroke. It doesn't help. Get off now. Okay. And they destroyed a cohort of women. Wow. Not true. Not true. Not true. I call it like a zombie adage. Zombies that they forever. Estrogen doesn't cause cancer, breast cancer. It may promote a cancer that is there, but it's not going to cause cancer. Estrogen doesn't cause cancer.
Got it.
One more time, estrogen doesn't cause cancer.
If I'm somebody who's had cancer and let's say I'm in remission, can I take estrogen?
The tremendous thought on this is that this should be no for systemic for the one reason that is if there's a recurrence, it could be estrogen receptor positive. So if it's estrogen receptor positive and I'm giving you estrogen, I could promote it. Yeah. And make it show itself a little bit more. But those women that look at the risk and they say, I'm willing to take that risk, I don't see it. And if they do take HRT and they do develop a breast cancer, it's usually of lower grade, less likely to have metastasized, and usually found sooner. Because these women who are doing these hormones are wanting to thrive and improve, so they're going to listen. They're going to take the old adage of an ounce of prevention is worth a pound of cure. So when you ask them to do a breast exam, when you ask them to do a mammogram, they're doing it.
They're doing it.
They're doing it. Okay. And medicine is able to find these things sooner. The testosterone is different. Testosterone can, convert to androstenedione and go back into the pathway and make more testosterone or not. Yeah. Testosterone can do a number of three things. It can go, androstenedione is one. Yeah. 2, it can continue down and become estrogen.
Oh, okay.
It can convert to estrogen. Or it can convert to DHT, dihydrotestosterone, which is the most potent testosterone.
All right.
Okay, so it has those three options.
Okay.
So people think, well, hey, testosterone will change to estrogen. Well, they looked at women and they looked at females that were transitioning to male. So that means they have to take high dose testosterone. So when they did that, they looked at it and they said, my goodness, the female to male they had more cancer. They did have more cancer, but when you compared it to the control group who didn't take testosterone, they were significantly reduced in comparison to the group that didn't take testosterone.
Oh, that's interesting.
So testosterone, in some ways, we're starting to believe that it's protective against breast cancer.
All right. So that's really individualized, though.
Yep.
What are some other things that if somebody comes in with those kind of typical ailments around sex doesn't feel the same, sex may be painful, dryness, that kind of a deal, and they've had cancer, they don't want to go near hormones. Can they do anything else? And the thing that I'm looking for here is something that you turned me on to as well as somebody else today. So I feel like it's in the air.
What's that?
Is that carboxy?
Oh, yeah, carboxytherapy.
Yeah, let's talk about that.
Yeah, carboxytherapy is amazing therapy. Basically, what you're doing with carboxytherapy prior to CO2 carboxytherapy that we have here in the United States is that it's usually injected. So it's usually a gas. And so you put CO2 in areas that you're trying to heal or improve.
Yeah.
And what that does is it makes the body interpret that as, hey, there's a lack of oxygen in that area. We need to really push blood flow to that area, increase oxygenation in that area. Your hemoglobin is what carries oxygen.
Yeah.
It'll carry this oxygen to the different parts of the body.
Sure.
So, but when there's high concentrations of carbon dioxide,
the
hemoglobin changes shape and has a greater affinity for carbon dioxide.
Yeah.
Now, when it changed shape, it dropped off a whole bunch of oxygen in order to grab up that CO2.
Yes.
Right?
Okay.
So that it got more oxygen at the spot to get rid of the CO2 that's bad for us and get it out of it.
Ooh,
Right?
I kind of like
Because when
that.
we breathe, we're breathing off CO2.
Yes.
The trees take in the CO2 and give us oxygen.
Such a gorgeous partnership. It really is. Like, really, when you think about it, it's like, wow, that's happening.
Yep. You take 2 packets, you mix the packets together. It creates a gel that puts off CO2.
All right.
So you can put it on your face.
Ooh.
So it's causing a healing process, right? It sends the body into a healing cascade. So you increase blood flow.
Yeah.
You increase collagen. You increase elastin. So you're improving the tissues of the vulva.
So is that going to help with dryness? Is that going to help with?
Yes.
What's going to help with?
Yes, it'll help with dryness. It'll bring a lot of fluid and oxygenation there. So when we bring in more blood flow, you're bringing in more blood vessels, which means you're bringing in more plasma, and that plasma can then shift, and that's where we get our moisture in the vagina. If I take this carboxytherapy, put it in the vagina, you let it sit overnight. She does it herself.
Okay.
She mixes it, takes in a syringe, puts it in the vagina.
Syringe. Okay.
Rubs a little extra, whatever she may have, put it on the outside, lets it sit overnight.
It stays there?
Stays there. Wake up in the morning, stand up, use the restroom, falls out, you take a shower, you're cleaned off, and you've had your first treatment.
So that can help with dryness. That can help with like irritation, and definitely is something that someone with or have had cancer could do.
Could do, yes.
All right. You know, a lot of the non-invasive things you can't do if you've had cancer.
Right.
So I just think it's good to know that there's hope and there's options for people who have had it or are currently going
knowledge and choice, right? The
knowledge
more knowledge
and
you
choice.
have, the more choices you have. Or you could say awareness, options, and solutions.
I like it.
Any one of those works.
I like it. You developed a procedure that's a little bit different than how anybody else does a labiaplasty. And if I'm getting this right, I think it's because you kind of came up with it because people you saw had botched labiaplasties and you were like, uh-oh, what do I do? Then you came up with a solution. So
I did.
What was the deal?
So here's what's out there right now. So
all right.
As it stands right now, wonderful surgeon, Gary Alter in Beverly Hills.
Yeah.
He came up with a procedure where you actually use Can I use this model? So,
well, you brought it, so yes.
Yeah, okay. So here we have the vulva, right?
Yeah.
So then what they do is they take a little bit of this excess tissue, bring it down this way, and bring it down this way.
All right.
To create an illusion of a labia. That labia are there.
Okay.
Right. And it can be a stepwise process. So what I've done is created a way that it doesn't matter if they've had a clitoral hood reduction. Because if you had a clitoral hood reduction, you don't have the excess skin here to create the labia. Or what if you're someone who was born that way? Or you had a labiaplasty where they did do the hood, so then now you can't get repaired. But my procedure is very similar to a procedure called grooving. That was done by Red Allenside. Now, his procedure is called grooving, and it creates the illusion of labia.
Okay.
So when you look, you say, yeah, there's labia there. Huh.
Okay.
But the procedure I've done is an extension of that, so that when they're healed, they will have labia.
Clitoral hood. Reduction. Why does somebody get that? Why do they want that?
Everybody, when they think of the labia, they just see these big old labia, right? And they say, I got to get rid of those labia. So they get rid of them, they make it smaller, it's tucked in, it's not going past the labia majora, it's nicer, but now you got all this hood here, and guess what's under there is the clitoris, and all this together kind of comes up, and they call it a penis deformity.
Oh.
So they have so what you're losing then is proportion. So they're symmetrical from left to right, but from top to bottom, top heavy, light. So when we do a clitoral hood reduction, all we're doing is working on the sides and getting rid of the skin on either side so that everything is not only symmetric, but proportional. And then what we do is we just make an incision right along this interlabial fold.
Okay.
Remove some of the skin that's sagging, right? So I've removed that portion of the skin, and now I'm just taking this part of the edge and sewing it to here.
Got it.
So facelift, tightening. Facelift of the vulva.
It's very similar.
Yeah.
Very similar.
Yeah.
Okay, so we got the majora. Go to the minora.
Labia minora.
Got it. All right. And that could also be like splaying way out.
Yep. It could be way out.
And,
it could be tiny, small.
Let me just say, if it's splaying way out, but it's not uncomfortable, it's not like you have to go get a labiaplasty.
You also could say, well, I have smaller breasts. Just because I have smaller breasts, I have to go out and get a breast aug?
Thank you. That's a perfect way to see it. No. Yeah. But if you want it,
go get it.
Then go get it.
Right. And here would be the urethra, where you urinate from.
Yep. Mm-hmm.
And then under here, where this pink area is, which is go about an inch, centimeter and a half, 2 centimeters, somewhere in there is the G zone or Grafenberg's zone.
Yes.
Okay. And that's what this represents here.
Okay.
Now, inside this vulva, guess what I have?
I don't know. I do not know. Oh, it's so cute. It's so cute.
So there you got the hot pink button. Everybody knows that. Then you have the crus, or the legs that kind of hold the clitoris in place.
Yeah.
And then you have these vestibular bulbs.
Okay.
Now, these vestibular bulbs have erectile tissue in them.
Ooh. Say
So
more about that.
So when you get excited and aroused, these bulbs engorge.
Oh.
So you have an erection. It's on the inside. It's on the anterior vaginal wall.
Okay.
So with each stroke of the penis toy or finger, you're pushing on these vestibular bulbs, which are part of the clitoris, which has the 10,000 plus nerve endings and double that of the man's.
Yeah.
Thanks to Carolyn DeLucia. All right. She put it out there.
She did.
All right. So sometimes as women age,
Yeah.
the clitoris will get smaller. It doesn't get as much blood flow, and orgasms may take longer to achieve
Okay.
or become more muted.
And that's because there's just not the same amount of blood circulating.
Mm-hmm. That's why some women will use Viagra.
What?
Yeah. You can improve blood flow in the clitoris with Viagra.
Regular Viagra, the same Viagra that a man would take?
Yeah, but at about 20 milligrams instead
And
of 50.
Okay, so typical man 50, you take 20.
Mm-hmm. That can improve blood flow to the clitoris.
Okay, I don't feel like that's common knowledge.
Probably is.
Wow.
That's why we're here.
Oh my God. Okay.
And another option that improves blood flow is PRP, platelet-rich plasma.
Yes, that's the O shot.
O shot, orgasm shot.
That's the O
developed
shot.
by Charles Reynolds.
Right, exactly. And we talked about that with Dr. DeLucia, and that is readily available, with you, with other providers. Absolutely.
Yeah.
The O shot is PRP. It's something that is
safe.
Yeah, it's safe.
Works.
Okay, so if I am thinking about this procedure. And let's just go with a labiaplasty.
Okay.
Okay, but I'm not in Davis, California, but I've heard of you. And I'm like, I think I want to have a consultation. Can you have like a virtual consultation,
Yes.
just like you would with somebody who would be doing your nose?
When you come on board to make an appointment, we'll send you a packet. In that packet has photograph instructions.
Okay.
You'll have instructions to go, just like you said, front, left, right.
Okay.
And then they can take pictures of anything else that they may be bothering them.
Yeah, got it.
And then I like them to give me a little bit of a wish pick, so I can begin to get into the mind's eye of the patient as far as what they're wanting to accomplish.
Got it.
Because people, right, patients have cosmetic desires,
Interesting.
but then there's anatomical realities, right? Okay. So I get the pictures.
Yeah.
I look at them. We get on Zoom.
Okay.
And then we're talking, we're given the talk, and then I say, Jacqueline, let's share your pictures. And I'll share the picture,
Got it.
go up on Zoom, you have it there, and then I use my cursor and I just show you, hey, this is the potential incision line I would draw.
I see.
This is where I would do it. This is how we would does that look good? What would you want? How would you want it?
Very
She
effective.
tells me, and I say, yeah, I could do all that. This is how we would do it. Then we talk
Got
about
it.
recovery, these kind of things.
Okay.
And then I tell them, well, the last thing will be when you arrive, we'll do an in-person exam. I'm going to touch you. I'm going to draw. I'm going to actually draw the lines on you. You're going to look at them, and you're going to say, nah, doc, make that in a little bit more or take it out a little bit more. Because I have a lot of tools. I can do a lot of things, but I'm not the wearer.
No.
I don't wear this
You're
thing.
not.
So what I might think might be really cool, you might go, oh,
No.
right?
I love how enthusiastic you are about this. And you're clearly so passionate, and you were delivering babies for, decades. And then, like you said, totally moved across the country and, changed your whole life.
I want to thank the women in Omaha, though.
Oh, you should.
I love them.
Just take a moment.
Can
and
I
thank
tell them
them.
thank you? Thank
Yes.
you so much for everything
you, women
you've
in
done
Omaha.
for myself and my family. We love you.
Aw.
And I do miss you.
Oh,
I actually
good.
went
That's
back
nice.
about a month ago,
Yeah.
and I actually gave a grand rounds at Creighton University.
Oh, wow.
Really opened the eyes to about 30 residents and about 6
Nice.
attendings in the community.
Okay.
And just kind of share with them all the different things that we do. So it was great.
It is not typically thought of as a comfortable conversation.
No.
It's just really not.
Yeah, it's tough.
But I think the more we talk about it, the more comfortable it gets, right? Because if
That's
we
the
never
whole
talk
idea.
about it, we've never heard it, and it's like labia.
Yep.
But then now you hear it. Now you've had a conversation about it. Now you've seen it on this lovely soft thing you have here.
Yes. Called the vulvar puppet.
The vulvar puppet.
The vulva puppet.
Okay, I like it.
It's handmade too.
Oh, it's nice. Can
They can
someone
make a whole bunch of different ones. You can go to
Oh, really?
the vulva puppet.
.com?
I think it is. And you can order different ones. And
No way.
Yeah.
Will they custom do it, like
Yeah.
colors and everything?
Yeah.
So I think the more we have these talks, the better.
Absolutely.
And then, for someone who is curious about these things, they can go to that tool on your website, which we'll put on ours too, which is the questionnaire
Yes.
to ask your doctor.
Yes.
Or now, like I did, I kind of did some Googling around and then found also other doctors who do their vaginoplasties on YouTube. And then, of course, you can look at their websites. And I think, like you said, if they really demonstrate that as a specialty and not as, oh, yeah, we do that too.
I think
Right?
you're right.
Don't you think that's
Exactly. Yes.
number one?
Yes, I think that's a really good point. To
Because
bring
if they're
about.
putting it out there and going, yes, we do this, then that gives me a lot more confidence than somebody who's like, I do a lot of abdominoplasties or I've delivered a lot of babies, but sure, I can do that.
Right.
So-
and you also got to remember that physicians are people. Sometimes they're
Yeah.
not comfortable talking about sex,
Right.
so they could be uncomfortable.
They could.
Physicians need to take some ownership in this as well.
And that's part of what you learned with Dr. Goodman was how to talk to patients.
Absolutely. And give you some constructive information back that could help you to thrive and live your life better.
Yeah.
That's what I do.
Yeah. All right. So how do people find you? What's the best way to find you?
thecosmeticgyn.com.
thecosmeticgyn.com and Dr. Michael Reed, REED.
.com.
.com. How about your social media and your YouTube
Social
channel?
media is The Cosmetic GYN.
Okay.
And then YouTube is Dr. Michael Reed.
Okay, well, there you go.
And then you can also check out LabiaMenoraReconstruction.com.
Ooh.
And there you'll
Bonus.
find, yes, it is a bonus.
I like a bonus.
You'll find a whole bunch of information about Revive. And there's a picture, a little video of before and after.
Oh, wow.
We've had a few handful of patients now that have been extremely happy with the outcome.
Okay.
And it's just so wonderful to be a part of this. Be a part of educating, be a part of creating a surgery that will help a lot of people.
Yeah. Thank you so much for being here. It's been enlightening, and I really love your passion. Love what you're doing.
And thank you so much for having me and
Yeah.
being able to share my expertise. And I also want to thank you so much for doing this for so many women.
I'm Jacqueline Buckingham. Welcome to your most powerful chapter. Wherever you are on the pause spectrum, this is where you begin. Go to joinmeno.com and get early access. These are the answers, and we bring you the experts that have them.